Thank you so much, Matthias. Good morning, everyone. So today I'll try to answer a clinical question with you, and we will look at the risk stratification of sudden cardiac death using cardiac MRI. Thank you. But before, so this is my lab. We are based in Bordeaux, southwest of France, and I wanted to show you this picture for two reasons. First, it's because this is the only day of the year where we had a blue sky, and also because this institute, so this is an IHU, Institut Hospitalo-Universitaire. We had 6 institutes before when it was created 15 years ago, more or less. Now we have doubled this number recently, and now we have 2 of such institutes in Bordeaux. This one is dedicated to cardiology, and the new one will be dedicated to neurology, and maybe there will be a very strong interaction between the two IHU. And this building is very interesting for us as MR physicists because we have 3 MRI systems, 1.5T and a high field 9.4 Tesla system, fully dedicated to research, plus other ultrasound. And other very interesting technology, and the PCCT as well. We talked about the PCCT. There is a PCCT sitting right here. So feel free to come and pass by, and we'll be happy to show you this institute in Bordeaux. So yeah, today my goal is to maybe answer the question I had yesterday, is that find a clinical question coming from a clinician and try to see how we can answer this question with our tools, the tools that we have at the Institute, and the expertise. We need multiple expertise to answer this question. And today we'll talk about the risk stratification. So when you have myocardial infarction, we will proceed with a revascularization of the coronary artery. But we need to know, and this is one of the hot questions in cardiology, we need to know if this patient who had myocardial infarction will die from it in the 5 years. That's what we call sudden cardiac death, or if this patient will have a new arrhythmia, a new infarction, or heart failure. Because we have a device that is very useful in case the heart stops in the 5 years. This is called the defibrillator. This is what you see here. And the cardiologist needs to know if in this patient who had myocardial infarction, we will implant this device to save his life in case his heart stops in the 5 years. And today, the cardiologist will base this decision on one parameter, which is called the left ventricular ejection fraction, EF, there. And we will get this parameter with MRI or with the Jean-Luc's ultrasound device. And if it's below 35%, the guidelines are saying we will implant the defibrillator in this patient. If it's above 35%, we don't really know. And it's likely that we won't implant this defibrillator. The problem is that if you look at the studies, 80% of the patients who will die from sudden cardiac death after myocardial infarction have a fraction of ejection above 35%, 80%. So it's not efficient. The other problem is that when we implant the ICD, the defibrillator, only a small portion of the patient will really benefit from this therapy. So some patient will be shocked by the device, but there was no reason for shocking the patient. Or sometimes the device will never have to be used, right? The patient will not have sudden cardiac death in the 5 years. So there is really a problem today. We have the clinical question here. So when we heard this question from our clinician, we thought maybe imaging could be the solution, more than just one single parameter, which is the fraction of ejection. And this is, these guys in Germany tried to answer this question. Can we get more parameters from MRI to predict the risk of sudden cardiac death in patients with myocardial infarctions? So they had the idea to recruit almost 1,000 patients with acute myocardial infarction. They will use all the sequence available in their MRI, look at all the parameters possible, and see after 1 year if we can correlate these new biomarkers, these new parameters with the MACE event, which means did this patient had a new myocardial infarction, experienced sudden cardiac death, had cardiac arrhythmia, or another infarction. And this is very interesting they realized that, yes, the fraction of ejection is still there, so it's still a useful parameter, but we have 3 more important parameters. The infarct size, the size of the lesion on MRI, if there is the presence of microvascular obstruction in these images, and the size of the inflammation. So we have 3 new biomarkers. So in total, we have 4 important biomarkers that could help us to predict the risk of sudden cardiac death. If you look at the MRI, we can quite easily get these parameters. So you might have seen this acquisition, which is one of the best sequences that we have in cardiac MRI. It's called the Cine acquisition, and with this Cine acquisition, we will extract a lot of parameters, and mostly this fraction of ejection. We will look at the fraction of ejection from Cine. We will assess the inflammation using T2 mapping. This is a great sequence that we use in clinical practice. And my favorite sequence, the LG sequence, to assess the size of the scar and the presence or the absence of microvascular obstruction. So today, it's impossible for me to show you the 500 sequences that we use in clinical practice, but I'll show you these 3 sequences that are used for risk stratification, and I will show you how we can improve the current protocols. But before, let me show you an image that we get with cardiac MRI. This is a short axis slice that the radiologists quite like, because we see on this image nicely the 2 ventricles. So we cut the heart in the middle, in there. It's called the short axis. On the right, the left ventricle. On the left, the right ventricle. It's very interesting, I know. And we could also see the myocardium that is separated by 2 layers, the epicardium and the endocardial. And we have the blood cavity of the left ventricle in there, the blood cavity of the right ventricle in there. And if there is a scar, we want to assess the size of the scar. Remember, this is a very important biomarker. We will see it with bright pixel within the left ventricle. So this is a typical example, but I'll come back on this kind of acquisition later. So first, the Cine sequences, we want to extract the fraction of ejection. So the Cine sequence is performed in the beginning of the examination. The examination takes about 45 minutes, if we're lucky, sometimes way longer. And that's actually one of the big challenges of cardiac MRI. It's too slow. And this is very useful. So we will look at the motion of the wall, the motion of the left ventricle. We will extract the cardiac mass. We will extract the fraction of ejection with this acquisition. We could look at the valves right here. We could assess, as I said before, and quantify some parameters, the fraction of ejection in our case, or we could do some very interesting colored representation of 4D or 5D flow, as you can see here. But today what we're going to do is we will look at this software here, and we'll look at how we can extract the ejection fraction from this image. So the cardiac Cine is very simple. We continuously acquire data. We split the ECG in multiple cardiac phases, and we will have to fill the same number of case space, right? So if we split the case space, the ECG, the RR interval in 4 cardiac phases, we will have 4 case space to fill. So the first part of the ECG will fill the first line of the first phase. The first part of the ECG for the second heartbeat will fill the second case space line, and so on and so on. In practice, we have between 20 and 30, 35, 40 cardiac phases that we will collect, depending, of course, on the heart rate of the patient. So guess how we're gonna now get the image from this case space? Someone? Very easy. The Fourier transform, right? Super easy. We apply these beautiful mathematic tools from Joseph Fourier. Anybody knows where Joseph Fourier come from? Marseille? No. From Auxerre. From Auxerre. So he's a French mathematician, and this is amazing what he did in the 80s, right? We did not have the MRI at this time. This tool is used, revolutionized the field of MRI, I'm sure you could tune your guitar using a Fourier transform. You could compress the images coming from space. So it is something in the 80s that is really impacting our field today. And for me, this is a very magical tool, and we will see another one later. So we simply do a Fourier transform of all the cardiac phases, and we will get our cardiac cine images. So that's what you'll get on the left. And this is used in 100% of our patients. So we always do a cardiac cine acquisition, always under breath hold, and we use this so-called BSSFP acquisition, which provides a great contrast. You see the great contrast between the myocardium and the blood, and this is a fast acquisition. You see a problem here. This is another challenge with cardiac MRI. We ask a lot of breath holds to our patients. Most of the acquisition are performed under breath holding. If the patient do not manage his or her breath hold, this is what we get. And we have tools to correct that, motion correction tools. So I'm not gonna detail this technology, but Matthias gave a very nice talk last year here in Cargese on motion correction, so I'm sure it was recorded. Then we have the cardiac cine images. If we had cardiac motion, we will repeat the acquisition with a better breath hold. And the radiologists are using this software to extract this fraction of ejection. Is it below or above the 35%? This tool will give this parameter. And I wanted to show you this tool because this sequence is probably the only one in cardiac MRI where we could fully automate the analysis of the images. This software will fully automatically detect the endocardium contours, the epicardium contours, and extract the fraction of ejection fully automatically. Right? This is probably the only sequence where we use AI to perform this task. So now we know if this patient had a fraction of ejection below or above 35%. Now we need to know the size of the inflammation. And T2 mapping is great. So for the last 10 or 15 years, we were using qualitative imaging, black blood imaging, but since 10 or 15 years, we are now using T2 mapping. T2 mapping is very efficient in the field of cardiac MRI. Each pixel has a physical sense. In milliseconds, we saw the mapping yesterday, so we use it for cardiac MRI. At 1.5 Tesla, just to give you an idea, the healthy myocardium has values below 50 milliseconds, above, so around 60 or 70 milliseconds. This is typical of an inflammation. And we use that technology on all the patients coming from for acute heart disease suspicion in the field. And I invite you to read these two papers where they compare all the mapping technology, and you clearly see that when you have acute disease, acute cardiomyopathy, edema, inflammation, T2 is elevated. So this is a great technology. But before we were using this technology called the dark blood T2 weighted imaging, which was very, very cool. And if you have this sequence in your center, I invite you to try that and to push the resolution because you'll see the small fibers. I really like this sequence. But there is a massive problem. That dark blood technology is based on the flow of the blood within and outside the slice that we try to image. So not only this is restricted to 2 dimensions, but also when the blood is not moving so much, we'll have bright pixels on the images. And the radiologist could think that this is inflammation, which is not. This is inflammation here. This is not inflammation. At the apex of the heart, the blood is not moving much, and so we have bright signal on the images. We don't have this problem with T2 mapping. T2 mapping is not based on the flow of the blood. So that's our T2 mapping sequence in the field. So you recognize the ECG. We always trigger the acquisition on the ECG. You recognize the readout here. So again, we use a BSSFP readout at 1.5 Tesla. And to generate this T2 weighting, we will integrate a T2 preparation pulse just before the readout, and we will increase this duration. So no T2 prep, a T2 prep of 25 milliseconds, and a T2 prep of 55 milliseconds. And that's what Philips, Siemens, and GE do in their system. And this is interesting because this T2 prep has been developed by Matthias here. So, and the story is very interesting. So please ask Matthias the story about the T2 prep and the patents and etc. It's really interesting. So this works in 9 heartbeats, and we have 2 recovery heartbeats between the acquisition. Remember why we have the recovery heartbeats? We mentioned that before, yesterday. We need to wait for the magnetization to recover fully, so that's why we wait and we do nothing for 2 heartbeats. So we collect 3 T2-weighted images, we see the different contrast, and we will use this mathematical equation. We will do a fit, a mono-exponential fit, to extract the T2 map, and that's as simple, and this is very efficient technology. And that's what you will get for patients that we had in Bordeaux. When you have myocarditis, non-ischemic heart disease, you'll mostly have elevated values in the mid-wall, in the mid-ventricle. When you have myocardial infarction, which is exactly our clinical case here, we're trying to solve a question for patients with acute myocardial infarctions, the edema will mostly touch a big part of the left ventricle with the full thickness of the ventricle will be impacted by the inflammation. When we have rejection, mostly the whole heart will have elevated T2 values, and sarcoidosis, a couple of patches. We are in this case here, and we want to measure the size of the inflammation, the size of these green pixels. But just to open a parenthesis, this T2 mapping technique is very useful in many cardiomyopathies, and we use it also in Takotsubo cardiomyopathy. I don't know if you've heard about the Takotsubo cardiomyopathy. This is, I would say, a woman disease. It impacts 90% of the women who have, in this population, in this Takotsubo population, 90% of the patients are women. This is stress-induced. And when you look at the heart on cardiac MRI, the left ventricle looks like a jar, like that. So there is the heart is really, because of the stress, remodeling, deformed. And how we diagnose Takotsubo with cardiac MRI? So these patients are coming to the emergency room with chest pain, with acute coronary syndrome. So we need to know if this is myocardial infarction or this is something else. And what we do, we could do 2 sequences in this population. We will do the lead gadolinium enhancement sequence that I will present later to see if there is a scar, so myocardial infarction, or we'll do a T2 mapping sequence to see if there is elevation of T2 values. And if T2 is elevated and LG negative, this is Takotsubo cardiomyopathy. So these 2 sequences are really powerful in these patients. So far we've seen cardiac CNA to extract fraction of ejection. We've seen T2 mapping to extract the inflammation, the edema. Now we want to know the size of the scar that has been caused by the infarction. And here we will use this LG sequence, lead gadolinium enhancement acquisitions. And this is, with CNA acquisition, probably the most powerful sequence in cardiac MRI. So that technology was developed in 1999 or 2000 with a landmark paper. So I invite you to read this paper in the New England Journal of Medicine. This is probably the only technology that has been published in this journal, like MR technology that has been published in New England Journal of Medicine. And here they, for the first time, they presented this inversion recovery for cardiac scar imaging. So 25 years old, and this is used not only to diagnose, so what we do today is to do the risk stratification, but we use it to diagnose the patients. We could use that technology to guide ablation, so that's what we mentioned yesterday. The cardiologist will ablate the area where we have the scar on the LG images, and that's something we do every single day in Bordeaux. More recently, you could use these images to build the digital twin. And this is very interesting. We could simulate therapies on models before doing the therapy. So for example, for cardiac ablation, we will build this kind of model. We know the actual physiology equation, so we can simulate a lot of simulations and ablation points and find the best points that we will use for ablation the next day. So the cardiologist doesn't have to try many points, but he knows, thanks to these digital twin models, where to ablate the patient. So this is very useful. And yesterday we talked about animal experiments. This could be one solution to also avoid animal experiments, right? Build digital models of the experiments. But today we are going to look at risk stratification, and we will measure the size of the scar on these images. That sequence is performed at the very end of the protocol. We have collected the cine images. We have collected the T2 maps already. We will inject a dose of gadolinium. We will wait about 10-15 minutes, and we will collect a lot of lead gadolinium enhancement to look at myocardial scars. That's the sequence. It's very easy to implement and to simulate. And for those of you who are interested to enter the MRI field, that's very a good first exercise. You recognize the sequence that we had before. We need the ECG. We collect the image with some kind of BSSFP or gradient echo readout. And what you recognize is a new pulse here. So this is not a T2 prep anymore. This is what we call an inversion recovery, a pulse that goes 180 degrees. And that's it. What's interesting is this parameter. We need to find the optimal delay between the inversion and the acquisition. This is called the inversion time, or the TI, and I will show you why this parameter is important. So we have the sequence, and we can simulate this sequence. Yesterday, with Professor Ekberg, we heard about the block equation, and this is a very efficient tool. We could simulate this technology and see the behavior of the signal over time. And if we do that with this inversion recovery acquisition, we have this kind of behavior. We invert the spins, then we wait the inversion time, the magnetization is going to recover, and we will collect the image at a specific time point in the ECG. And what we see is that when we simulate the block equations, purple, the healthy myocardium, green, the scar, we realize that at this exact time point, the inversion time, the TI, when we will collect the image, the healthy myocardium will be at 0, which means black, dark signal on the images, while the green signal, the scar, will have a positive contrast, so bright pixel on the images. That's as simple, and that's the image you will get if you implement this sequence well. Black pixel for the healthy myocardium, bright pixel for the scars. And that's what the kind of diagram the radiologists use in practice. If you go to your department, they might have printed this graph, because with these LG patterns, you can really classify the patients and the cardiomyopathies. So we are in the case of myocardial infarction, right here. The scar is always touching the subendocardial layer here, always touching the blood. For example, when you have dilated cardiomyopathy, rarely the scar will touch the blood, the endocardial layers. If it's mid-wall, we can really classify this patient as a dilated cardiomyopathy. If we have diffuse disease like amyloidosis, the whole left ventricle will be impacted. And so on and so on. For hypertrophic cardiomyopathy, we'll have patchy enhancement on the images, mostly located on these two areas here. So you see the power of LGE to classify the cardiomyopathies. What we're looking at today is the subendocardial scars. We need to now measure the size of this scar. Is it above 19%, as the German paper was saying, or below? So we grabbed the images, we collected the images. We hope that the patient really holds his or her breath perfectly. And if we have good image quality, we will have to process these images. So this is done manually. We have a couple of technologies coming actually from Nancy. You might know the team of Jacques Féblinger and Damien Mandry. They compared all the tools that we had in place to segment the scar. So they look at what we call the full width at half maximum. To do so, we look at the histogram of the pixels in the healthy myocardium. We take a region of interest in the bright pixel, the scar that we see on the images. We take half of the maximum, so this is the scar, right? Bright pixels are here. We take half of the pixel, and what's above this threshold will be considered as a scar. Or we have the other technique that is called the NSD technology, and standard deviation. Here we take a region of interest in the healthy myocardium, so every time the radiologist has to draw this region of interest. So now we look at the healthy myocardium. We are in this part of the histogram, and we will put our threshold above a certain amount on the standard deviation, 2, 3, or 4 standard deviation. And these guys in Nancy tried to compare all these semi-automated techniques to see which one was the best. And what's interesting is that in the conclusion, if I remember, they said that the full width at half maximum was the most reproducible, but the manual delineation was, at the end of the day, the best, right? So we have semi-automated tools available, but the manual segmentation performed by the radiologist still remains the state of the art. So that's what they do in practice. And this is interesting. If you go in Marseille in your radiology department, or in Los Angeles, or wherever, you'll see that the cardiac radiologists are really drawing circles most of the day. They are looking at the endocardial contours, the epicardial contours, and then they draw the scar manually. So in Bordeaux, it's at least 5 hours of segmentation per day. So it's huge, right? They have, I don't know, 12, 15 years of medical schools to, at the end of the day, draw circles for 5 hours. So again, this is a clinical question that scientists have to solve, and AI might be one of the solutions. So you might ask, why can't we use like automated tools to do this segmentation of the scar? We have these tools existing since 2010 or something like that. What's going on with these semi-automated tools? So this is a review paper that I found published recently, where they look at all the AI tools available, published, all the articles where they were doing scar segmentation on LG images. So they compared all the parameters. They used the DICE. The DICE is a measure of segmentation quality, of overlap quality. And they realized that the best tool available was giving a score of 66%. 66%, if you take a picture of your hand, you rotate it by 180 degrees, you take the DICE of these two segmentation, this is 0.66. So the best algorithm available today performs not so well, actually. That's why, that's the reason. 66% of DICE is quite bad. And I took this example in Bordeaux, a typical patient. We could see a myocardial scar here. I asked my two radiologists to segment this scar. Yes, they detected the scar, but if you look very closely, there's a lot of differences in the segmentation of the scar. So that's a problem, because we need an accurate segmentation of the scar. We need to know if it's below or above this 90% of the size of the left ventricle. So we need the most accurate segmentation possible. So there is a clinical problem here. Let's go back to the images. So here are 3 other patients we had in Bordeaux with myocardial infarction. That technology works pretty well, right? You can see it. We have the bright pixel. We have bright pixel here. Yes, this patient has myocardial infarction. This patient might have 2 coronary arteries occluded. We see it pretty well. The problem is that in between 15 and 20% of the population, we have contrast issues. These are 3 other cases we had in Bordeaux where our 2 radiologists did not agree on what they were seeing. Here we see bright pixels touching the subendocardial layer, you remember. Is this myocardial infarction, or is this artifacts breathing artifacts, blood, whatever. Same here. They did not agree. One of the radiologists was saying, oh yeah, this is scar. The other was saying, no, this is blood that is trapped between the papillary muscle and the healthy myocardium. So they did not agree. Same there. Look at this kind of hyper enhancement here, but it's not so obvious here. Isn't it motion artifact as we saw on the cine images before? This impacts 15% of the population in Marseille, in Bordeaux, in New York. We all use the same technology, so we all have the same problem. And this really impacts not only the diagnosis, sometimes we don't know what to say for this patient, but also the segmentation, right? If we don't even agree on the visual aspect of the scar, how can you segment this scar? So this is really complicated. So what's the problem? Let's go back to the block equation. Remember, we were simulating the healthy myocardium, 0 at the inversion time, positive for the scar at this time point. What about the blood now? If we do the block simulation and we look at the signature of the blood, we realize that the blood has a positive signal that is very close to the scar. So here is the issue. And I'm going to go back on the images. Now that we know that the blood is the problem, this is true, right? Remember the anatomy that I showed you before? This is the blood with gray pixels, and the scar is supposed to be bright, but we have clearly a problem of contrast here. Same here. If there is a scar, the signal is too close from the blood, so we cannot separate the blood from the scar. So this is the issue. So let's do a summary of what we saw so far. I still have 10-15 minutes. We saw that we have multiple sequences, T2, LGE, CNA. These are 3 out of 500 sequences that we use. Repeated breath holds. We need to ask the patients to hold his or her breath a lot of time, at least 60 times per protocol, so second challenge. And this is a nightmare for the MR technicians. If you look at the MR technicians, they are really experts in their field. They need to understand the 500 sequences. They need to planify the acquisition while talking to the patient, because we have to ask the patient to hold his breath. This is a really complicated job. And then the problem is that not only, apart from CNA, the analysis is not automated. We have to do this manual segmentation. But since we are using 3 different sequences, they are not registered between them. So the radiologist really had to draw these circles on all the images we collect. He's not going to do it once and then propagate the contours on the T2, LG, CNA. They have to do it on all the images. 3 different sequences, 3 different breath holdings, different acquisition parameters, different resolutions, so there's no way we can overlap these segmentations. And then we saw another issue, right? There is a contrast problem in the images. So all of this is really what we heard around this coffee that I was talking about yesterday. The clinicians were saying this is a nightmare for us. And at the end of the day, we know that these parameters are very important to risk stratify these patients, but they are not used in practice. It's too complicated. The radiologists, they will never stratify the risk based on MRI. It's too complex. So we know that we have important biomarkers, but we are not exploiting fully the field. So we need to solve that. So the first question was, let's look at this contrast issue on LG images. There is a problem of contrast between the blood and the scar. We've heard about the dark blood images for T2 weighting before. Can we exploit this information? The blood is the problem. We don't care about the blood. We want an image without blood. And the field has really progressed in this topic. And we have now a lot of technologies coming where they do black blood imaging and even black and bright blood images. So let's have a look at the sequence here. It's a typical sequence. We have the ECG, we have the readout. This is where we collect the image. We have the inversion pulse, as we've been doing for 25 years. Now maybe we could plug something like Matthias developed, this T2 prep, in there to modulate the signal. So we tried it, and many people tried it in different labs, and we realized that by adding another preparation pulse, at this inversion time, now we have the signal of the blood, which is the green signal that is also at 0, which is exactly what we want. At 0 means we won't receive any signal. These will be dark pixels, black pixels. And that's what you get in theory, based on the Bloch equations. And we can exploit also the recovery heartbeat. Remember the recovery heartbeat where we do nothing? Why not collecting an image in the recovery heartbeat to extract the anatomy? So that's what people are doing now. And this is very interesting because that's what you will get at the end of the acquisition. So here's the patient with myocardial infarction. You recognize the scar here. Perfect case. With this new black bloc technology, you'll get 2 data sets that are perfectly co-registered because these images are collected in the same threshold. Black blood, you see the scar. There's no more signal from the blood, which is exactly what we want. And here we have a bright blood image, which looks a little bit like the cine acquisition. And now we can really exploit that, exploit the anatomy of this image. We can even fusion these images. They are co-registered, so we can extract the scar in color. So this is great. We solved one of the 3 challenges that the radiologists had. I'll be quick on that, but you could see that this is very useful in the patients where the radiologist did not agree. For example, here we know that something's going on in this area. There's a thinning of the myocardium, but if I ask you all to segment the scar here, we will have 50 different segmentations. Not the case anymore. Okay, so we solved one of the problems, but we still have another issue, which is the T2 mapping sequence that is collected separately to this acquisition. Can we combine this acquisition in one single threshold? So we go back to the acquisition, and this is actually Victor who developed this sequence. Victor is right there. He looked at the black blood acquisition, and he realized that we were actually using a T2 prep in this heartbeat, like T2 mapping was doing. Why not collecting multiple of these images with different T2 prep durations, so different T2 weightings, and generate a T2 maps out of that? So that's what they implemented. And at the end of the day, I think I have a nice video showing you how it works. In one single click, you'll get the black blood images co-registered to the bright blood images for the anatomy and for the scar detection. You could do this fusion if you want, but by using a mono-exponential fitting, you could also extract the inflammation because you could get a T2 map. So many information in one single threshold. Think about the processing now. We will just have to draw once the circles and propagate the information on the image that we want to assess. Exactly like that. Why not using AI to segment the left ventricle and then propagate these contours on all the images we've collected? They are perfectly registered and extract the information that we want. The scar, the size of the inflammation on the T2 map, and the presence or the absence of microvascular obstruction. We see microvascular obstruction right here. So we have 3 out of the 4 biomarkers that the German paper was mentioning. These are results. I'm gonna skip that. Maybe look at these patients here, where you see, for example, in this patient with myocardial infarction, the one we saw before, a big inflammation way above the threshold that was proposed in the article, a size of the scar way above the 19% of the ventricle, combined with LVEF that was below 35%. We know that this patient would really benefit from the implantation of the ICD. And we could do it fully automatically, actually. People have been looking at this. This image is using a BSSFP readout, exactly the same readout that we do with Cine acquisition. So when you look at this acquisition, you recognize a contrast that is very similar to Cine. And remember, for Cine, AI tools are working very well. We can use AI to segment the left ventricle. And that's what Thais has been doing very efficiently. You could train AI with a few patients, and these AI tools will segment these 2 contours with a very good dice. I think the dice is way above 90%. And extract the diagnosis informations. To do so, so Thais doesn't know anything about cardiac MRI and cardiology, but she knows about ChatGPT and the transformer models. I'm sure you have used ChatGPT models. This is so efficient, we could use it for our task, which is segmentation. What she did is that she took 500 patients where we have drawn manually the endocardial and epicardial contours. She plugged that into this ChatGPT model, it's called the transformer model, and she could extract this segmentation very efficiently. Don't ask me about this diagram and med transformer. This is absolutely not my field of expertise. It works so well that I asked Thais to run these transformer, these AI tools on a different sequence, not LG sequence, but cardiac cine or mapping, and this is working so well, even though the model has never seen this kind of images before. So I really invite you to actually try these tools for a task like segmentation. What's great with our field is that we were talking about open source, open data yesterday. We have access to the MRI system. That's a Siemens system. And what's cool is that we could plug these AI tools directly in the system. It's not fully open, but open enough that we could plug this, and it enables the radiologist to really test our tools quickly. So here, we collected the data. You didn't see, but the AI was running in the background. And in this patient, we could directly inline extract the left ventricle, the information about the scar, et cetera, et cetera. So the MR technician that is running the sequence knows the diagnosis before the radiologist, which is very interesting. Okay, but now you might ask, what if it's too late? What if the patient has already been implanted with a defibrillator? We need a follow-up scan. We need to know how the scar evolved over time. It's not too late. There are new technologies called wideband technology that could help you use these sequences in practice. The device will usually generate this kind of artifacts. That's why in practice, when a patient has a pacemaker or a defibrillator, we will not scan this patient with MRI. We will send him to the ultrasound imaging or to the scanner because of this huge artifact. Pauline, sitting right there, is using a technology called the wideband. She takes the pulse, the inversion recovery, the T2 preparation, the readout, and she decided to increase the bandwidth of these radio frequency pulses. And by doing so, you get nice images. That's what she got recently in patients with myocardial infarction, with scar, implanted with a device. You clearly see less artifact than the one I saw you before. So you could use that technology for most of the sequences, for the conventional LGE, or for black blood imaging, or for colored imaging, like this acquisition. You could even do motion correction of this data set if the patient does not hold his or her breath. And finally, so we have found a couple of solutions, but you might realize that CMR is still very inefficient, right? Remember, we have the ECG. We usually trigger the acquisition in mid-diastole. We also have the respiratory dimension. We ask patients to hold their breath in end expiration most of the time. So if you look at this two-dimensional space, you realize that we are just exploiting a tiny part of the examination, of the ECG examination, mid-diastole and end expiration. But we have missed a lot of information here. This makes CMR, cardiac MRI, extremely slow. Actually, we exploit less than 2% of the time spent by the patient in the MRI. There have been solutions coming out, and the team of Matthias is doing a lot of revolution in this field. Let's forget about the ECG. Let's forget about the breath holding. Let's forget about the electrodes. Let's collect images continuously with a very smart sampling. This could be a variable density or what they call the spiral phyllotaxis acquisition, where we always collect the K-space center. The K-space center, we have the low frequencies in there. We have most of the information of the image, so we have to collect this information. And this will be used later to retrospectively bin the data set in different motion states. So continuously, without electrodes, you'll get a 3D advanced case space, and now you have to think about how you're gonna get the images. So you could bin this data set in the dimension that we want. We could bin the data set in the cardiac dimension and the respiratory dimension. You fix the number of cardiac phases, you fix the number of respiratory phases that you want. You have split the data in multiple case space. Remember how to reconstruct the images? Joseph Fourier. If you apply the technology of Joseph Fourier, that's what you will get. Good images, you recognize the heart. Very interesting, you see the heart moving with the respiration. You see the heart contracting with the cardiac beating, but you have a bad image quality. So this is the second technology, in my view, that has really revolutionized the field. Compressed sensing reconstruction. I don't know if you've heard about compressed sensing, developed by this guy in Stanford in 2004, so quite recent. And it's been used this to compress the images or to better reconstruct the data set. And if you apply compressed sensing, you'll get this kind of data set. This is the equation he's trying to solve. And we've seen that from our PCCT expert in the room before. It's more or less the same equation. We just change the variables that are in this operator, and we will regularize the images. We will basically denoise the images in the new dimension that we have collected in space, in the respiratory dimension, and in the cardiac dimensions, and you get better images by using donor host technology. So for those of you who have never heard about compressed sensing, I invite you to look at that. This is really a revolution. And you could do 5D or even 6D imaging if you think about contrast and T2 mapping. So this is really a solution towards the one-click push-button acquisition without ECG, without electrodes, without breath holding, and maybe in the future we'll see all these acquisitions retrospectively reconstructed using this kind of free-running acquisition. One single click. Look at the images. We could extract cine acquisition for diffraction of ejection, but also T1 and T2 map beating. We could see the scar and the inflammation beating. We can even look at carotid imaging, small vessels in the body. That's what Isabelle has been doing there. And I think this is really impressive. So in conclusion, you see that from a small coffee in the hall, we had a clinical question, and we realized actually that this clinical question could be split in multiple clinical questions: contrast issues, breath holding issues, multiple sequences, motion correction, and the only way to advance this field and to answer this question is by combining multiple expertise. So he had in the team someone who could do block simulations, someone who could implement sequences, someone who could do AI, remember, someone who could do wideband imaging for patients with devices. We need all these expertise to be able to solve these questions. That's all I wanted to say today, and thank you very much for your time.